All right, good morning, good afternoon, good evening, wherever you are, and welcome again to this TechNet webinar on new single-dose HPV vaccination evidence and resources. Today I'm happy to welcome, one of our panelists. We're still waiting for some of our panelists in Seattle. We hope that they're just not thinking that that they're aware that we actually changed time here in Europe. In the case they're not aware, this means that they will be late and then we will have to postpone the webinar. But we give like a few minutes to Keisha, who will introduce you to some information on the topic. In the meantime, I would like to remind you that we are recording this webinar and that will send you the links to the video as well as the presentation by email. In the case we have to postpone the webinar because our panelists are not present with us, and I'm really sorry about that. If it's the case, then we will let you know by email about the new date. We hope that they will arrive soon. Finally, if the webinar can occur normally, then you can ask your questions during the webinar at any time, and you can write them in the Q&A box or the chat box at any point, and the presenters will answer them after the presentation. A final note, someone asked in French if there will be a translation. There will be no translation, no interpretation for this webinar, unfortunately. So this webinar is in English. Ce webinaire sera en anglais. Il n'y a pas d'interprétation en français ou en espagnol. Really sorry about that. Keisha, the floor is yours.
All right, thank you very much, Alex. I'm just going to quickly share my slides and please let me know if you can see them. All right. Okay, so thank you. Good day, everyone. I'm Keisha from the London School of Hygiene and Tropical Medicine. And today I'll be presenting the work that I've done with Mark Brisson and his team at University of Laval and Jane Kim and a team at Harvard. Using modeling, we assessed the global impact of the single-dose HPV vaccination schedule. And in this work, we also collaborated very closely with Ian from Public Health England. And we received financial support from the Single-Dose HPV Vaccine Evaluation Consortium, the Bill and Melinda Gates Foundation, and the Canadian Institutes of Health Research. So I do apologize in advance that some of my colleagues in Seattle might not be aware of the fact that the clocks move 1 hour ahead. My presentation was actually supposed to be towards the end of the webinar, but I will just give a start so that we can hope for my colleagues to join later on during the call. So there are many different types of data sources we would need to estimate the impact and the cost effectiveness of the HPV vaccination program. For most countries, we have the population age structure and cervical cancer incidence and mortality from the IARC Global Can. For some countries, we only know the population HPV prevalence and the type distribution, as well as age of sexual debut and vaccine delivery costs. However, only for a handful of countries do we know their detailed sexual activity and prevalence of precancerous states. So the PRIME model, which is short for Papilloma Virus Rapid Interface for Modeling and Economics, employs data that is available across most countries. Currently, the updated PRIME can estimate the direct impact and cost effectiveness of HPV vaccines for more than 190 countries. However, the base of this static model doesn't account for the herd effects of all vaccine waning. For more complex dynamic models such as the HPV Advise, PHE, and Harvard models use more data types to estimate the impact and cost effectiveness of the HPV vaccines while accounting for herd effects, vaccine waning, and more. However, these advanced models, which are data hungry, can only be conducted for a handful of countries where data is available. Suppose we would like to understand the possible impact of HPV vaccine in more countries. We could use the modeled indirect vaccine impacts from the dynamic models to impute the indirect vaccine impacts waning for other countries and include this into PRIME. This would give us a range of plausible vaccine impact and cost effectiveness. And in today's session, I'll be presenting the results of this approach. To assess the impact to which one dose HPV vaccine schedule will provide sufficient protection and the cost effectiveness, we compared the impact of under 3 different vaccine strategies. First, the counterfactual, no HPV vaccination. Second, a one-dose HPV vaccination schedule where we assume one dose of the HPV vaccine confers either 20 or 30 years of protection, or if one dose confers lifelong protection, but at 80% vaccine efficacy. And third, a two-dose vaccination program schedule where 2 doses of the vaccine would provide lifelong protection. For the one-dose vaccination schedule to be cost-effective, it first has to be cost-effective to move from 0 dose to 1 dose, and it also has to not be cost-effective to move from 1 dose to 2 doses of the vaccines. Here, we synthesize results from 3 published dynamic models, the HPV advised models for India, Nigeria, Uganda, Vietnam, and Canada, the Harvard model for India, Uganda, Nigeria, El Salvador, and the United States, and the Public Health England model for the UK. We then compared the cost effectiveness of 1 dose versus 2 dose vaccination in 192 countries using PRIME, assuming that 1 dose vaccine provides a shorter duration of protection or lower vaccine efficacy, by estimating and comparing 3 aspects of the impact and cost effectiveness. First, we looked at the number of cervical cancer cases, deaths, and DALIs averted. We then looked at the number of females that would need to be vaccinated with 1 dose and the number of females that would be required to give an additional dose to complete a 2-dose schedule to avert 1 cervical cancer case, death, or DALIs. And we also looked at the threshold cost to pay for the first and second dose of the vaccine. This is basically the maximum that could be paid for the first dose compared to no vaccination, and for the second dose compared to 1 dose only, for the incremental cost effectiveness ratio to remain below the country's specific cost effectiveness threshold. Here are some of the model assumptions. In particular, we assume 80% vaccine coverage and the routine annual vaccination schedule to be from 2021 to 2120. We adopted a 3% discount rate for costs and health outcomes, and also performed the analysis with no discounting. One way to assess the impact of the 1-dose vaccination schedule is to look at the number of cervical cancer cases. Here, we presented the number of cases averted by income groups. So you have the income groups running across the rows. And so suppose we assume that 1 dose confers 20 years of protection, and this would be the first column of the plot. We then compared the projected number of cervical cancer cases averted in low-income countries from the 11 country models. We also find that the projections are consistent across all of the models, all the 11 models, even though they were built independently and in different settings, other than us harmonizing the key model assumptions that I mentioned earlier. So the white area in this plot actually represents the 100 years of routine vaccination of 10-year-old girls at 80% coverage, representing the years 2021 to 2120. The gray areas represent the additional cases in the vaccinated cohort after the 100 years of routine vaccination. So should 1 dose of the vaccine confer a longer duration of protection, say 30 years, or provide lifelong protection but a lower vaccine efficacy? These are the plots in the second and third column. More cancers would be averted, although the differences are marginal. We observe similar trends in middle-income countries and high-income countries. There are many countries in the middle-income group. With more vaccinated individuals, naturally, more cancers can also be averted. For the high-income countries, we find that much fewer cervical cancer cases are averted or present in general. Although there are more countries in the high-income group than in the low-income group, we see that there are 4 times fewer cases in the high-income countries than low-income countries, even after adjusting for their population sizes. Here we present, next we present the proportion of cervical cancer cases that may occur under a routine 1-dose vaccination schedule with an imperfect vaccine compared to a routine vaccination program with a perfect vaccine. In this analysis, we only considered the 9-valent HPV vaccine types. I should also mention that the y-axis on this figure is from 0 to 15% and not 0 to 100%. So basically, compared to a perfect vaccine, the 1-dose schedule conferring 20 or 30 years of protection would avert about 95% of the cases. Similarly, if 1 dose of the vaccine provides lifelong protection but at lower vaccine efficacy, the majority of the cases, about 98%, can still be averted. And that's what you see in the rightmost column of this plot. assuming that the vaccine wanes at 20 years after vaccination, the PHE model parameterized with data in the UK projected that a routine one-dose schedule would miss less than 1% of the cases, and that can still be averted by a routine program with the perfect vaccine. In this case, we assume that the two-dose vaccination schedule is the perfect scenario. However, the HPV advice and the Harvard models, which are mostly parameterized with data and from lower middle income countries, projected about a 6% of the cases could be missed. Because the PHE models are calibrated to UK data, it suggests that a larger proportion of the infections would lead to cancer would occur within the first 20 years of vaccine protection. However, the HPV advice and Harvard models may say otherwise. Data from low and middle income countries could suggest that populations are at risk for a longer duration and thus may need a vaccine with a longer duration of protection or more doses to see the same effect. Having said that, across all income groups, you see that the two-dose vaccination schedule conferring lifelong protection would only avert slightly more cases than the one-dose scenarios. Another aspect to consider would be the number of girls needed to vaccinate with one dose and the number of females required to give the additional dose to complete a two-dose schedule to avert one cervical cancer case. Here, we have the number of girls needed to be vaccinated with the first dose in the gray region. In other words, moving from no vaccination to one dose. And the estimates are presented on the log scale in this plot. And the model provides consistent results for the number of girls that we need to vaccinate with the first dose to prevent one cervical cancer case. Fewer girls are needed to be vaccinated with the first dose to prevent one cervical cancer case in a low-income country than in a high-income country. In the white region, we have the number of girls that we would need to give a second dose to complete a two-dose schedule, and all models show that we will need to vaccinate many more girls with a second dose to prevent one cervical cancer case. Here we're looking at requiring to vaccinate about 300 to 5,000 additional girls, depending on the epidemiological profile of the country. And if we discount the health benefits, the number needed to vaccinate to avert one cervical cancer case increases because you basically value future health less than you value health today. So the small differences that you see in the population impact of the one-dose versus two-dose programs underscores the significant potential public health impact of one-dose vaccination schedules if vaccine uptake is high across all countries. Although HPV supply constraints motivated this research into alternatives such as the one-dose vaccination schedules, we didn't really account for the supply of the vaccine in this particular piece of modeling work. I would like to thank, again, the financial support that we received from the Single-Dose Vaccine Evaluation Consortium and the Bill and Melinda Gates Foundation, and there are many contributors to this piece of work. So I guess some of my colleagues are able to finally join the call, and I'm glad to see them here. Meanwhile, I'm happy to also take questions. Sorry.
Thank you very much, Keisha. I see Anne just joined us like earlier. Anne, would you like to take the floor, and maybe we can answer questions at the end of the presentation? I just sent an email to our colleagues in Seattle who may have missed the fact that we changed time here in Europe. So they might be just waking up now and ready to join us hopefully very soon. Anne, would you be able to take the floor?
Yes, certainly I can do that. So do you want me, so obviously the presentation was thought to be, first the introduction, setting the stage, and then yes, presentation of some of the clinical data and observation studies, and then the modeling. So do you want me to give you, so the introduction was supposed to be done by Evan. So we can in a way do that.
Okay.
Wait until they come, and then that could be the wrap up at the end of the day. So
okay, Anne, here's a possibility. I see Tara just joined us. In case the meat of the information has to be delivered by Evan, who's not with us now, we may have to postpone and perhaps redo this webinar at a later stage. This is a possibility. It's up to you.
No, I think Either I can start with the first part of the presentation if you want me to do so. So we can start from the beginning.
Okay.
We have heard already the modeling, so that's perfect.
Okay, good. Well, then the floor is yours.
Okay. So thank you very much. So good morning, good afternoon, good evening. So now Evan was supposed to actually present the slides. So Keisha, do you have the slides?
I think Tara might actually have the PowerPoint presentation. I only have access to the PDF slides from the single-dose vaccine consortium. Meanwhile, while you're looking for the slides, there are actually a couple of questions in the Q&A. Alex, is it okay if I just take them very briefly right now?
Yes, go ahead.
Okay, great, thank you. So I'm just going to address Kunal's question. So what are the data for the 20, 30 years and 80 years protection associated with the one dose based on? So you asked the question at a very timely point. There are several slides that were supposed to come before mine where they talk about evidence from the trials and the observational studies. So a lot of the assumptions that we make for the modeling work on the one-dose vaccination strategies are based on some of these observational studies as well as trial results. As for another, I hope that answers your question. You can, if you want, you can develop more follow-up and I can address it in the chat. As for Sanjay, the last slide, does it mean that low coverage with one dose is better than a high coverage with two dose? So I think what I was trying to gather at is, I'm not saying that a low coverage with one dose is better than a high coverage with two dose. In fact, I'm saying that if you can ensure high coverage, vaccination coverage in all countries with one dose, which if you did a two-dose program means you can only offer less than half to a few countries, it's actually much better to, the public health impact would be higher if you allowed for more countries in the world to achieve high vaccination coverage with one dose of vaccine. Yeah. So I hope that answers the question, rather than having a high coverage with two dose versus a low coverage with one dose. So that's not what we're doing here. Thank you. And I think you're mute. Yeah.
Yes, I tried to see how I can share my slides. So share screen there, I think I have it. Can you see my screen?
Yes.
Can you see the slides?
Yes. You can make it full screen if you want.
Yes. How to do that? Okay. So I hope.
Oh, no, it's not working.
It's not working.
Maybe if you change the display setting, yeah, or something.
Can you see it better?
Yes, better.
Okay.
Thank you.
And you see here the Zoom probably. Okay. So good morning, good afternoon, good evening, and I'm very sorry that we were not really aware of the change in time. So my name is Anne Trind, and I'm a pediatrician by training, dedicated the major part of my career to clinical research of vaccines. I joined PASS in mid of last year as initiative team leader for HPV vaccine. So it's my pleasure actually to present to you some evidence of the single-dose HPV vaccine that has been compiled by the evaluation consortium. Next slide. Oh, next slide is me, sorry. So cervical cancer is a leading cause of cancer death among women in low and middle income countries, with more than 85% of the cases occurring in low and middle income countries. And there is a yearly new incidence of new cases of more than 600 cases per year, with more than 340,000 deaths, and 85% of the deaths occur in low and middle income countries. So HPV has been shown to be present in virtually all cervical cancer and is a necessary cause for cervical cancer. In November of 2020, the WHO launched a global strategy to accelerate the elimination of cervical cancer as a public health problem. with a 2030 goal of achieving 90% of girls fully vaccinated with HPV vaccine by age 15. Then there are two other pillars that relate to screening as well as cervical cancer treatment. So the current HPV vaccines are prophylactic. That means they need to be administered prior to exposure with HPV, and this optimally before sexual debut. So the HPV vaccines were first introduced in 2006 on a 3-dose schedule. And there is, meanwhile, accumulating evidence that a single dose of HPV vaccine may elicit an immune response that can protect against HPV infection. And I'm going to show you some of this evidence in a little while. It's important to know that the HPV vaccination schedule has been reduced before, and this in 2014. The WHO reduced the schedule from 3 doses to 2 doses in people below the age of 15, following an evidence review by the Strategic Advisory Group of Experts on Immunization, SAGE. So this slide shows you the actually the current recommendation by the WHO, which is to provide 2 doses of vaccines for girls 9 to 14 years of age, with some flexibility for the second dose that can be administered at least 6 months past the first dose. For girls above 15 years of age, or for people with immunocompromising conditions, a 3-dose schedule is still recommended. And then the table shows you the vaccine that are currently available. 3 of those vaccines actually receive a WHO pre-qualification. The bivalent vaccine Cervarix, the quadrivalent vaccine Gardasil, and nonavalent vaccine Gardasil 9. And one additional vaccine, which is Secolin, manufactured by Inovac Xiamen, is under review by the WHO for pre-qualification. It is to be noted that currently Gavi-supported vaccines are Cervarix and Gardasil 4. All those vaccines contain HPV 16 and 18, and those are really the 2 major types that causes cervical cancer, and they account for approximately 70% to 80% of cervical cancer worldwide. So this map shows you actually the introduction of HPV vaccines and compared to the burden of disease of cervical cancer. And you see that the highest burden, which is in the darker orange colors, is in low and middle income countries. And these are the areas of the world where the introduction is still not fully implemented. And it is to be noted that 70% of the girls targeted for HPV vaccination, which are girls 9 to 14 years of age, live in a country where there is actually no national program for HPV vaccination. So if demonstrated to be effective, a single dose HPV vaccination could accelerate the introduction for countries that have yet to introduce the vaccine. Obviously, with 1 dose, you could target more countries that if you have a 2 or 3 dose schedule. That would facilitate the current national program by simplifying delivery costs and also lowering the program costs. And that will reduce the potential for supply shortage and delivery challenges, such as those that we are currently facing in the current pandemic for vaccination. So in 2018, the single-dose HPV vaccine consortium was established, and the consortium encompasses 8 leading health and research institutions and work together to collate and synthesize the existing evidence and evaluate new data as they arise on the potential for single-dose HPV vaccination. So the consortium synthesized the evidence from trials, clinical trials, observational studies, as well as modeling into one paper. The last edition is now available and was released end of 2020, with the next edition that will be available in 2022. And each evidence review is also accompanied by a synthesis and a summary in 3 different languages. So now I'm going to present you some of the evidence from single-dose HPV vaccination from clinical trials and observational studies. So let's first look at some of the rationale for single-dose HPV vaccination strategy. So the current HPV vaccines administered on multi-dose regimens are highly efficacious in preventing persistent infections. And persistent infections are a necessary prerequisite for the development of cervical cancer. The vaccine has also been shown to be highly efficacious in preventing cervical lesions associated with the types included in the vaccine. And as I mentioned before, HPV 16 and 18 account for more than 70% of the cervical cancer worldwide. The vaccines elicit a strong and durable neutralizing antibody response. And we know that neutralizing antibodies are thought to be the main mechanism for vaccine-induced protection and need to be present prior to exposure to the virus. The antibody response elicited by the vaccine has shown to be stable with data that span up to 10 years post-vaccination, and seroconversion rates are virtually 100%. Now, there have been some data, and I'm going to go into more depth in the next few slides, on a single dose administration. And what was observed is that the antibody response remained sustained over time. And even if the quantity of the neutralizing antibodies is somewhat lower, the quality of the immune response is similar after a single dose compared to multi-dose vaccination. And another observation that was made very early on in the development of HPV vaccines was that pre-adolescents mount a higher immune response than the immune response seen in adults. So what is the evidence from clinical trials? So a systematic review was conducted on the efficacy and immunogenicity of a single-dose HPV vaccine administration compared to either multi-dose or no vaccination. And reports from 4 studies were found through that search. Except for one study, which was small immunogenicity in 10 subjects, data originated from randomized controlled trials and very large trials where participants have, some of the participants have failed to complete their allocated 2 or 3 dose schedules. The search did not yield any randomized controlled trial that directly compared 1 dose to 2 or 3 doses. However, data from 2 large vaccine efficacy trials with long-term follow-up, and those trials are still in follow-up, are the basis for the concept of single-dose vaccination. And those trials are the Costa Rica vaccine trial, as well as the India IAC trial, and you will hear a little bit more about them later in the presentation. So what were the main findings from all those studies is that after vaccination, the incidence of HPV 16 and 18 infection were extremely low in all trial participants having received HPV vaccine compared to those that were unvaccinated. Also, the efficacy against HPV 16-18 infection was comparable following 1 dose, 2, and as well as 2 dose or 3 dose in healthy young women, and this up to 11 years post-vaccination, which is quite a long period post-vaccination. And then in terms of immunogenicity, the proportion of participants seroconverting to HPV 16 and 18, which were included as vaccine type, was very high, and this in all HPV dose regimens. So in the next few slides, I will present you some of the data from those clinical trials. So first, this table illustrates the vaccine efficacy against HPV 16-18 infection after different dose regimens. And this is an analysis, a combined analysis from 2 major vaccine efficacy trials, phase 3 trial, the Costa Rica vaccine trial, as well as the Patricia trial that assessed the bivalent HPV 16-18 vaccine. So the table shows the dose stratified vaccine efficacy against HPV 16 and 18 infection, and this in women that were HPV negative at baseline. And I would like to draw your attention to the bottom part of the slide that shows the vaccine efficacy against HPV 16 and 18 infections that persisted for at least 6 months. And as you can see, the vaccine efficacy in the prevention of persistent infection was very high. And the vaccine efficacy was similar between the 3-dose vaccine recipients, the 2-dose vaccine recipients, and the single-dose vaccine recipients. That means that protection after a single dose of HPV vaccine was demonstrated. In terms of immunogenicity, this graph shows the durability of the immune response after a bivalent HPV vaccine administration. And those data are again from the Costa Rica vaccine trial. So on the x-axis, you will see here the years post-vaccination, and on the y-axis, the antibody response. And this is for HPV 16 antibody levels, but the figures would be very similar for HPV 18, but I'm not going to show you that figure today. So what are the observations? So after vaccination, 2 to 4 years post-vaccination, you will see that the antibody level reach a plateau that is sustained over time, and here up to 11 years post-vaccination. This study is still ongoing and will yield data up to 16 years post-vaccination. So the second observation is that after a single dose, and this is the blue line, you see that the antibody levels are somewhat lower than after 3 doses. Here, the purple line, approximately 4 times lower. Nevertheless, and that's the important point, is that the antibody levels after a single dose are still much higher than after natural infection. So this is the black line here at the bottom of this graph, represent the antibody levels seen after natural immunity. And you can see that after a single dose, the antibody levels are 10 times higher, and this 11 years post-vaccination. So one can conclude that a stable antibody level up to many years post-vaccination can be achieved following a different dosing schedule, and those levels are far higher than natural immunity. Now I'm going to switch gear and show you some data from observation study. Again, a literature search was performed to identify results from 9 studies that look at immunogenicity in observational studies. So again, most of the participants were to receive actually an intended multi-dose schedule, and thus failed to complete their full vaccination schedule. The observations from those observational studies are well aligned with what was seen in clinical trials, as follows: that a single dose of HPV vaccine results in high rate of seroconversion as well as sustained seropositivity. And in observation study, the observations went up to 8 years post vaccinations. The antibody titers were lower following 1 dose than with 2 or 3 doses. But the clinical relevance of this observation is not yet clear, since the minimal antibody level sufficient for protection has not yet been identified. However, the titers in 1 dose arms remain stable over time and were considerably higher than with natural infection. And important to note that some of the adolescents demonstrated a higher antibody titers after a single dose than the titer that were observed in adult women receiving 3 doses in a clinical efficacy trial, and this using the same laboratory methods. And this is important since pre-adolescents are the main target for HPV vaccination, meaning vaccination prior to sexual debut. Now, in terms of effectiveness, it has been shown that HPV vaccine has been clearly efficacious in decreasing the number of cervical lesions following implementation of HPV vaccination program, and this really in different countries, and to name a few: the US, Scotland, Sweden, and Australia. So the systematic review looked at the evidence of HPV vaccine effectiveness by number of doses and yielded a substantial number of studies that reported on that for different outcomes in terms of infection or in terms of clinical outcomes. So most of the studies found highest effectiveness with 3 doses, followed by 2 doses or 1 dose. However, since the data were generated in the setting of national 3-dose vaccination program, they were subject to some biases. Women failing to complete the vaccination schedule might be at higher risk for HPV infection, and thus this would result in apparent lower effectiveness with fewer doses. Nevertheless, half of the studies found significant vaccine effectiveness for single-dose HPV vaccination in some or all analyses. Higher effectiveness estimates were found in a younger age at vaccination. And again, as I told you before, vaccine needs to be administered prior to infection to be effective. And so I think the last one is important to know, that in the more recent study that really looked at younger vaccine recipients, or with analysis stratified by age at vaccination, it was shown that a high effectiveness could be achieved following 1 dose, or in some studies, there was a similar effectiveness after 1, 2, or 3 doses. And again, this remains important, and I'm reiterating that point, since pre-adolescent adolescents are the main target for primary prevention of cervical cancer through vaccination. Now, I'd like to illustrate the findings with data from a national cohort study in Australia. So this was a retrospective cohort study that used linked regional data registries and assessed high-grade cervical lesions following quadrivalent HPV vaccination. So among the 250 women that were screened, 20% had not been vaccinated, so had received no vaccination. 70% had received 3 doses, and a substantial number, more than 8,600 women, received a single dose. and screening started up to 7 years post vaccination. So on the x-axis, you see the time following the start of screening, and on the y-axis, you see the probability to develop a high-grade cervical lesion. And what you can observe is that the vaccine conferred high protection against the development of high-grade cervical lesions. Here are the unvaccinated women in the pink line, and the vaccinated women are here in the purple line. And the second observation is that following 1, 2, or 3 doses, and you see that the curves are really superimposed here, there was no real difference between the vaccine efficacy in terms of preventing high-grade cervical lesion. So one can conclude that 1 dose had comparable effectiveness as 2 or 3 doses in preventing high-grade disease, and this in a high coverage setting in women vaccinated before the age of 15 years of age. So that would conclude the presentation of the clinical and observational data. And I don't know if Evan has joined at this point.
I am here, yes, and many apologies. Somebody snuck a global time change into my calendar and I didn't see it, so I apologize for that.
No worry, Evans. Maybe I gave you the floor for the last part of the presentation.
Okay, but I'll ask you maybe to do the advancement of the slides.
With pleasure, I will do that.
Okay, great. So again, apologies. My name is Evan Simpson, and I'm the vaccine implementation team lead at PATH, and I also manage the consortium. And so Anne and Keisha have presented some of the compelling evidence and information around single-dose HPV, but there's still work to be done. And as we look ahead, I wanted to share a little bit about what evidence is forthcoming and some additional studies that are underway. And that'll just take a couple of minutes. We have a couple of slides. There we go. So there are some gaps. There are still some questions. So we still need more evidence around the vaccine, and particularly some of the clinical studies that are underway to address the durability of protection, the efficacy, effectiveness, and immunogenicity of a single dose, and the standardization of laboratory assays so that we can work across the studies are also important. And all these things are underway. An updated systematic review is happening, and that will include newly published studies on efficacy and immunogenicity and single-dose effectiveness of HPV vaccination from observational studies, and new quality assessments of the evidence. So that's some ongoing work as well. And then evidence generated by future modeling work, some of the work that Keisha and her colleagues have been doing, will focus on integrating the new trial and non-trial information and data and the effectiveness data into these existing models that she shared, as well as conducting model-based analysis in low and middle income countries with different sexual behavior and epidemiological profiles and cultural contexts and all of those things that are important in assessing overall effectiveness. In South Africa and other countries with high prevalence of HIV infection, it will be critical to generate more evidence on the health and economic impacts of reduced dose HPV vaccination in HIV positive individuals and immune compromised individuals as well. So that's critical information, and there is an important study taking place in South Africa right now. Next slide. This table I won't go through in too much detail, but it just shares this is a table of all the clinical studies that are ongoing, clinical trials, and you'll see there's sort of a timetable associated with these studies. And you'll see that in 2021 and 2022, we expect to see a bulk of the data and information and evidence coming from some of the more significant clinical trials underway. And just looking down the list of studies along the left, some of the critical ones are the DORIS trial in Tanzania, the KENSHI trial in Kenya, The Primavera trials in Costa Rica, and a couple of trials actually in Costa Rica are important, as well as the India IARC trial. And we anticipate perhaps publication and data and information from India coming out later this year. And then lastly, down at the bottom, two really important impact studies, the Thailand impact study and the HOPE trial in South Africa. And we're hoping to see some of the evidence emerging from that later this year. Next slide. So lastly, these are just some of the available resources, and Anne mentioned the evidence review that the consortium has been generating. Associated with that, we have a number of other resources, including the fact sheet, the evidence review itself, a synthesis of that evidence review and a summary, as well as a consensus statement. And this is a statement that was put out by the consortium late last year, in which they sort of endorsed the WHO's extended interval recommendation. And so there's information there as well, and some of the evidence that supports the notion of extended interval. And then lastly, you can get some of this information through our website at the path.org single dose HPV site. So I think that's all. Again, I kind of rushed through that, and many apologies for the confusion this morning. So we can take questions. I think you can either ask on the chat or directly to us.
Yes, there's this. Hi, Evan, and welcome.
Hi, Alex.
You can ask your questions on the chat box or the Q&A box. I think there were like a few questions that were answered earlier. Is there any other question? I don't see any other question. So what's going to happen now, I'm going to share the link to the recording as well as to the presentation later this week. If Anne, Evan, and Kisha are okay with that, I will also add their email addresses, and I will send that to you, all the participants, and actually all the people who registered, even those who couldn't attend, so that in case anyone has any question, you can directly contact Anne, Evan, or Kisha. Oh, there's a question. So by when do you consider one-dose HPV vaccination will be made effective in Gavi countries?
That's a good question. So there's a process ahead of us. The single-dose HPV vaccination schedule would come about after a recommendation from the WHO SAGE. And so SAGE would recommend a change in the schedule. And then Gavi would follow, and they would likely then adopt the SAGE policy and recommendation. And so they would then communicate out to the Gavi countries that they would be supporting and financing a single dose schedule. But all that needs to is contingent upon WHO SAGE making a recommendation. Our hope is that in April of 2022, SAGE will take up the evidence around single dose, and by then, hopefully, there's compelling evidence for a schedule change. So that's the timeline, and so we need to have the SAGE recommendation before Gavi can then establish a policy for financing of single dose.
Thank you very much, Evan. Any other question? Doesn't look like it. Oh, yes. Well, no, that was to thank you. Okay, so I'm going to send, as I said, I'm going to send an email to all people who registered to this webinar with the address emails of the addresses of Evan, Anne, and Kisha. And if you have any question, you need more information, you can contact them at a later stage. Thank you very much. I would like to apologize again. Our colleagues in Seattle received a notification to log in 1 hour before the start, which was 5 o'clock in the morning. So obviously they didn't see it, and they were not aware that we changed time here in most countries in Europe. So, but we managed to have the webinar that went smoothly. Thank you very much, Kisha, for starting it, and thank you, Anne and Ivan, to join us in a very in this complex situation. Thanks everyone, and well, have a very good, very nice day or evening, everyone. Thank you very much.
Thank you.
Thank you.
Bye bye.